Intravenous therapy. Intravenous therapy is going to introduce liquid solutions and blood products directly into the bloodstream or areas that readily absorb these products into the bloodstream. It's going to help restore and maintain fluids and/or electrolytes, provide routes for medication administration, allow for transfusion of blood and blood components, and provide a route for parenteral nutrition. Direct access to the circulatory system provides rapid drug action. We can also achieve precise dosage calculation and flow rates through the intravenous route. It avoids pain and tissue irritation from intramuscular or subcutaneous administration, or oral drugs that may irritate the gastric mucosa or might be inactivated by gastric juices. The dose can be titrated to achieve desired therapeutic response. However, LPNs cannot titrate medications. We can do blood sampling. They can be obtained from many of the IV access devices. If drawing a sample to determine a therapeutic drug level, there's certain ways we do this. We're going to get a peak level once a dose is completed, if that is what is ordered, or the interval between completing and obtaining a blood specimen will depend on the specific drug. We can also do a trough level, which we would draw before administering the next dose, usually about 30 minutes prior to the next dose, and then that will determine if we're going to give that same dose or if we're going to give a different dosage range. IV therapy risks include bleeding, emboli, damage to the blood vessel, fluid overload, overdose because of rapid medication absorption, allergic responses or adverse effects, incompatibility to drugs and solutions, catheter complications, or interference with activities of daily living. We do need to understand that IV therapy is more expensive than oral or intramuscular medications. Pediatric clients. The younger the child is, the greater the risk of fluid and electrolyte imbalances. Pediatric they can also have an increased risk for fluid overload and congestive heart failure. Pediatric clients have immature homeostatic regulating mechanisms. In other words, a young child has a larger body surface in relation to weight. This results in quicker and greater fluid losses than the adult. And their metabolic rate is about 3 times faster than in the adult, and this increases water requirements greatly. When we insert an IV cannula, it needs to be performed in a treatment room, preferably not the client's room. This will allow the child to associate their bed and their room with comfort and security. We should use age-appropriate distractions to help take the child's mind off of the procedure. We can use topical anesthetics. If they're topical, they have to be in place for at least 30 minutes, preferably an hour, to get full effect. That topical anesthetic, though, can cause vasodilation. We can also give an oral high sucrose solution when we're inserting an IV in an infant, and this is very effective in reducing pain. Don't allow the child to see the equipment if possible. We should always prepare the equipment outside of the room. A lot of kids are really freaked out when they start seeing needles. And be honest with the child. Make certain they know that the needle is going to be removed, and tell them why the procedure is necessary in terms that the child is going to understand. Don't tell the child that the procedure is not going to hurt. Rather, that it will hurt a little bit, but you're going to be as quick as possible. Always have at least one other staff to help restrain the child, and we usually restrain above and below the potential insertion site. When we are starting IVs on children, then we frequently are having to hit a moving target. So be prepared that the child is often going to move despite restraints. It's not recommended to have the parent restrain if possible. We want the parent to be the one who comforts the child. When we initiate IV therapy on children, it may require visualization tools to help find the vein due to increased subcutaneous tissue. After the procedure, always praise the behavior, regardless of how cooperative that child was, and allow the child to talk about or play out their feelings. The child, when we're starting an IV, may only need the grasp of an assistant around the extremity instead of an actual tourniquet. We should also immobilize the extremity with a padded board if this is in the area of joint. But position that board in a manner that it does maintain the normal joint configuration. Administration sets used in the pediatric client are going to be micro drip. In other words, the 60 mLs or 60 drips per 1 ml, but it should be used with an electronic infusion device to help reduce the risk of fluid overload. The veins that we look for in the pediatric client are the peripheral veins. First of all, LPNs cannot initiate IVs in a child younger than 12, and LPNs can never do scalp veins. So these are the veins that we should be looking for when we're looking at the child. We do the dorsal hand veins or the metacarpal veins. Those are basically used for all ages. And we should always avoid using the dominant hand, or if they suck their thumb, avoid using that thumb sucking hand. Excuse me. Frequently, it will require splinting on the arm board, and it may interfere with the child's activity level. We can use the dorsal foot vein in a pediatric client who is not walking yet. Occasionally, we can use it for older children in the case of trauma or burns, but we typically will not do that once they begin walking. The antecubital fossa is generally unsatisfactory because of the need for immobilization. However, it might be more favorable in the older child. Try to use the non-dominant extremity again when possible. Always avoid the inner aspect of the wrist. Infiltration in that area can result in dangerous traumatic pressure, not only on the radial artery, but on the radial nerve, and cause permanent damage. With the scalp vein, these are readily available up to approximately 12 months of age, but it is preferable in infants that are 6 months and younger because of their hand activity. To dilate a scalp vein, we place the head lower than the rest of the body, and that will usually cause crying, and crying along with the lowered head will help dilate the scalp veins. It is really difficult to distinguish veins from arteries in the scalp. Again, LPNs cannot access scalp veins. And that IV site has to be well protected to prevent dislodgement. Central veins are going to be recommended for therapy that lasts longer than 1 week. We can do the percutaneous central venous catheters. This would be like the jugular vein in the neonates and the infants, although they don't have much of a neck, so this might be really difficult to accomplish. We can do subclavian veins in the older child and occasionally the femoral vein. We can do those PIC catheters or the peripherally inserted central catheters. This will go into the basilic vein, the median vein, the cubital vein, or the cephalic vein of the antecubital fossa. With neonates and small infants, we can use the umbilical cord until it dries out. We can also use a large saphenous, superficial temporal, external jugular, popliteal, and axillary veins. So let's talk about the older adult. There's things that are going to affect IV therapy with the older adult, such as the immune system. We start having these physiological changes. The immune system will become hypo-responsive to foreign antigens, but hyper-responsive to itself. And this means we have a decreased number of circulating lymphocytes, which results in decreased resistance to infection of the pulmonary system. The older adult has decreased subcutaneous tissue. They have decreased cardiac output at rest, and this makes them more sensitive to fluid shifts with infusion therapy. They don't tolerate it as well. The older adults have decreased tolerance to fluid excess or deficit, but they're able to show signs of, they're slow to show signs of these issues, requiring the nurse to monitor for those really subtle signs. With the older adult, we can administer fluids through the subcutaneous tissues or through the vein. The subcutaneous route would be used for fluid volume deficits or prevent dehydration. And we can administer some medications subcutaneously. This requires insertion of the needle at a right angle so the adhesive platform is pressed against the skin. Sites would include the posterior upper arm, the anterior or lateral thighs, and the abdomen greater than 2 inches from the umbilicus, but sites have to include sufficient subcutaneous tissue in order to absorb those fluids. Just like with a venous stick, we have to cleanse the skin well, preferably with chlorhexidine, and we have to maintain skin integrity. When administering fluids, we may need to rotate the site every 24 to 48 hours. But when only administering medications intermittently, that site can remain for up to 7 days. We always use the smallest gauge and shortest length device possible to effectively deliver the ordered therapy. With our site selection, and this is really for anyone, but also includes some of the older adult issues, always avoid those flexion areas. Avoid areas that have bruising. When possible, avoid the dominant extremity. In the older adult, avoid those small spider web type veins, those really tiny small ones. They're not very straight, they're kind of squiggly, etc. And in the older adult, we should avoid those hard sclerosed veins. Those veins are going to kind of feel like a small cord underneath the skin. When we palpate or try to dilate the vein, always do it gently. If we tap aggressively on the skin, it can actually cause a hematoma in the older adult because of the fragility of the vessels and the tissue. We also may not use a tourniquet in the older adult, especially if they have hypertension, because that can increase the risk of that vein rupturing when we put it on too tight. If we do use a tourniquet, apply it lightly to avoid over distension of those fragile veins. An alternative, just like with the child, have an assistant apply digital pressure with the hand above the intended insertion site and then release it once that vein has been accessed. With cannula insertion, it requires a decreased angle of insertion because there's less subcutaneous tissue, and that results in the veins being more superficial. Always apply skin traction below the projected insertion site. Direct method of venipuncture is often more appropriate in the older adult. When we stabilize that cannula, we have to consider the older adult's skin fragility. Make sure that you use hypoallergenic or paper tape and minimize the amount of tape that you use. Excessive taping can actually lead to skin tears in the older adult. As far as the dressing, we try to use that transparent dressing, and it also will help aid in stabilizing the cannula and decrease accidental dislodgement of the cannula. It also minimizes the use of tape on fragile skin. Now, we can do site protective measures that may be required if the client is agitated or confused or really restless. This means that we can put on a gown that has long sleeves. We can do hand mittens. Those are not considered a restraint, but it can prevent the client from actually picking at the tubing or the dressing. We can do a flexible elastic netting to cover the site, a padded arm board, or a commercially available IV site protection device. With the older adult, we need to recognize that they have a lower tolerance to rapid infusions. So, to be perfectly honest, in the older adult, 50 mLs per hour, 75 mLs per hour, up to 100 mLs per hour is considered pretty good. Occasionally, we'll do 125 mLs per hour. But if we do that for an extended period of time, they can become fluid overloaded very easily. We have to take care to prevent a runaway infusion. In other words, an infusion that all of a sudden dumps a large amount of fluid into the vein. So we have to set the infusion flow rate accurately and preferably use an infusion device such as a pump because they don't tolerate the large amounts. And make the roller clamp inaccessible to a client, especially a client that's confused, if we have to infuse it by gravity. Assessment of the IV site should always be ongoing. We're looking for evidence of fluid volume disturbances, electrolyte imbalances. We're doing accurate intake and output monitoring, frequently assessing the venipuncture site. And if an infiltration occurs, that fluid might drain away from the insertion site, so we may see it dependently. In other words, if we have the IV site on the top of the forearm, we may see it on the bottom of the forearm. We need to monitor for infectious process, and monitor for the expected therapeutic response to administered medications. So there's a variety of venous access devices available. The over-the-needle catheter device is the type that we will use in the IV therapy lab, and this consists of a plastic catheter attached to a plastic hub. We have a sharp needle that is used as the stylet. A stylet is basically what is going to guide the catheter into the vein. And the catheter is going to be slightly shorter than the stylet. We will then remove the stylet once we have successful cannulation, and we leave that flexible silicone catheter in the vein. With the winged infusion set, the needle is going to actually be attached to wings. We also call this a butterfly needle. There is a steel needle that is attached to those wings, and then it is also attached to a small administration set. We do not leave these needles in the vein for very long. We might use this type of needle to do a blood draw, or maybe we are just going to administer a medication one time into the vein and then remove it. And this would be ideal for that type of therapy. We have midline catheters. They're going to be inserted into the upper arm, and they are considered a peripheral device, even though they can remain in place for 1 to 4 weeks. We have intraosseous devices. They deliver fluids and or medications directly into the bone marrow. So we insert a needle into a large bone, with the upper anterior tibia being the most commonly used site. And it's often done with a special drill type tool. It's used during emergent situations when quick access of a peripheral vein is not possible. Maybe they've had significant blood loss and you just cannot palpate a vein, find a vein at all. So if we put that intraosseous in and give fluids, then later we can probably palpate a vein. The thing about the intraosseous or IO devices, they can only stay in place for 24 hours or less. Due to the pain with infusions, sometimes we will administer lidocaine to help decrease the discomfort. And it does require additional training to be able to insert these catheters. We've got the subcutaneous infusion ports that I talked about that we often use in clients that have limited vascular access for mild or moderate dehydration and or medication administration. But remember, it does require adequate subcutaneous tissue. We also have central lines. Central lines are going to be placed into large veins near the heart, and they're intended for long-term use. Infusion of potentially caustic drugs, or TPN, total parenteral nutrition, multiple concurrent infusions, central venous pressure monitoring, larger volumes of fluid, and we can also use them for blood sampling. Excuse me. We can provide multiple lumens with one catheter. It reduces the risk of peripheral vein irritation and prevents multiple peripheral IV sticks. It does come with its risks, though, and one of the risks is a pneumothorax. Think about where some of these large veins are. So if we're going into the subclavian vein, for example, the lung is right underneath it, and we could inadvertently puncture the lung with a needle. Another risk would be infection, thrombus formation, vessel perforation, or air embolism with insertion. It does require insertion by a provider. So usually this is going to be an anesthesiologist, a nurse anesthetist, or a physician. LPNs are not allowed to do blood sampling from central catheters if you are in the state of Kansas. However, in the state of Missouri, they can. There are several different types of central catheters. We have the non-tunneled catheters. These can be inserted into the femoral, subclavian, or internal jugular vein. They are intended for short-term use in clients requiring irritant or vesicant medications or potentially hemodynamic monitoring, such as the central venous pressure. We have the peripherally inserted central catheter, or the PICC line. This is a central vascular device, but we insert it into a peripheral vein of the upper arm, and then the catheter travels all the way to the heart. It's used in clients that require therapy longer than 6 days and can be left in place for several weeks. It can be inserted by a clinician that has had special training. This would be a registered nurse. We have tunneled catheters that are inserted into the chest during a surgical procedure, and they're used in clients requiring therapy longer than 1 to 3 months. We have implanted ports. These are inserted into subcutaneous tissue in the chest underneath the skin. And they're going to be used for clients that require long-term but intermittent therapy. These devices have to be accessed with a special non-coring needle in a right angle shape. We call this needle a Huber needle. These implanted ports, also known as portacaths, cannot be accessed by LPNs. Peripheral lines are going to be placed in the extremities or the scalp of an infant and are intended for short-term use. And there are therapies that are not appropriate for short peripheral catheters. This includes a continuous vesicant therapy. What is a vesicant? It's going to be a therapy that will cause damage and or necrosis to the tissue if it happens to leak out of the vein. We call that extravasation. They're not intended for chemotherapy, for parenteral nutrition or TPN, for solutions that have a very acidic pH or a very basic pH, or a solution that has an osmolality that is greater than 600. Any IV catheter or cannula, whether it's a needle or a catheter, can be converted to an intermittent administration device by attaching a needleless cap or an extension tubing with a cap. We call this a saline lock, and we basically use it for intermittent therapy. It is also available if there is a potential for needing a rapid IV access, but we don't necessarily need intravenous fluids. Advantages: it can be used for intermittent administration of medications, whether by IV push or IV piggyback methods. It avoids multiple venous punctures. Again, it has a prompt venous access. It has the potential for decreased fluid overload. It's very economical, and it also increases comfort and mobility. However, if it is not utilized frequently or flushed periodically with saline, there is a high occurrence of clotting. The intermittent infusion devices can be left in place the remainder of a hospital stay after we remove a continuous IV fluid solution. Well, how do we maintain IVs? Regular ongoing assessment has to be completed. That site has to be assessed and documented on at least every 4 hours. Assessment will be more frequent in a pediatric client, which has to be done every hour. Critically ill clients, clients that are getting sedatives, clients with cognitive alterations, or clients with infusion sites at joint flexion also need to be assessed hourly. Clients that are receiving vesicants in a peripheral site should be assessed every 5 to 10 minutes. Now, we ideally are going to infuse those vesicants through a central line. However, if we do not have a central line in place, and let's say our client's blood pressure drops to 70/48, it's very vital that we get a vasopressor going, and this is a significant vesicant. We're not going to take time to get that central line in before we initiate that vesicant. We'll get the vesicant initiated, get the client stabilized, and then get the central line in. So if we have to do something along that line, we're going to document and assess every 5 to 10 minutes. Assessment of an IV site is going to be assessing for the correct fluid, the flow rate, the volume of fluid, expiration date of the solutions, assessment of the dressing and the administration set, the dressing integrity, the site, and client complaints. It is recommended that prior to, after, and or between infusions that we flush intermittent devices with normal saline. So let me repeat this. Let's say we're giving intravenous push medications, and we have 3 medications to give. First of all, we do not mix the medications. We're going to swab the port closest to the client, attach our normal saline flush. We're going to aspirate the site, then flush that site with the normal saline. At the same time, we need to clamp the tubing and or turn off the infusion. I recommend clamping the tubing just above the site for the simple fact that the solution can travel up the tubing instead of traveling to the client when we push it. So then we remove the saline syringe, we cleanse the port, attach our medication. Excuse me. We are going to push the medication at the manufacturer's recommended rate, which usually is at least 2 minutes to push the medication in. but always look at your IV drug book for the correct rate. After we infuse that medication, we're going to disconnect. We're going to cleanse our port. We're going to attach another IV saline solution. We're going to infuse that IV solution, that saline solution, at the same rate as the medication, because that's what's still in the tubing going into the client. So we push it at the same rate as the medication. Once that's done, again, all the time we're clamping that tubing. We're going to disconnect the saline syringe, cleanse the port, attach the next medication. We're going to infuse that at the same rate that the manufacturer recommends. Once we're done with that, we disconnect the medication syringe, we cleanse the port, attach another saline syringe, and infuse the saline at that second medication recommended rate, and so on and so forth. So with our intermittent devices, we also need to lock the intermittent device with saline after the final infusion. So basically, we push a saline solution through the device. Some central devices, though, are going to require heparin flushes. Always follow your facility-specific policies for flushing. And many facilities have a pre-filled 5 or 10 cc preservative-free normal saline syringe. Those are very time-saving. The volume amount is usually going to be more than the amount of the internal catheter. Document each flush on the medication administration record. With our dressing changes, they need to be completed per facility policy. The gauze dressings will be changed every 48 hours. Even if you have a transparent dressing over a gauze dressing, it's still considered a gauze dressing and it must be changed every 48 hours. If it's a transparent dressing, we change that every 5 to 7 days. We change the dressing if the dressing becomes soiled, becomes wet, or loosens, or if there's signs of infection. A sterile dressing is applied to all venous access devices, whether it's peripheral or central. Make sure that you refer to your clinical checklist for the appropriate steps for dressing changes. It is very important to maintain digital pressure to the cannula when we are changing a peripheral dressing to help prevent dislodgement of that catheter. So never let go of the catheter if we remove that securement device. The central venous access device site care and dressing changes are going to be literally, they're both sterile dressing changes, whether it's peripheral or central. But we don't have to use sterile gloves for a peripheral dressing change, and we do not have to use a mask for a peripheral dressing change. So with the central venous device, we have to use a face mask not only on ourselves, but also on the client. Clients with a central venous access device at home need to be educated on signs of infection and dislodgement and to report those problems immediately. The solution we cleanse with is preferably a chlorhexidine solution. However, isopropyl alcohol is acceptable. There are prepackaged dressing kits available. Again, all dressing changes are done with sterile technique. We also have to label that dressing with the date, time, and initials of the nurse that's performing the dressing change, and then document the procedure in the medical record. Now, years ago, it used to be recommended that we rotate peripheral sites every 3 days, but it is no longer recommended to rotate those peripheral sites as long as there aren't any complications at the insertion site. If we do suspect a bloodstream infection, then we can always culture that catheter tip, uh, put it in a sterile cup, and then notify the provider and see if they want to run a culture on that tip. IVs that are placed in an emergent situation should be replaced as soon as possible due to the increased risk of introduction of pathogens during the insertion process. When you're in a hurry, you don't always follow proper technique. Administration sets will be changed per facility policy, but usually about every 96 hours. Tubing that is used to administer blood might be changed with each unit. For total parenteral nutrition, or TPN, or lipids, the tubing will be changed more frequently. Tubings need to be labeled to indicate when they should be changed. And an IV fluid container should not be used longer than 24 hours. Even if there's still half a bag left, we have to change that solution container. Every nurse needs to be familiar with the agency needle puncture and body fluid exposure guidelines. Infection prevention has to be in accordance with the facility policies and procedures, along with federal and state rules and regulations. PPE should be worn during all infusion procedures that potentially expose the nurse to blood and body fluids. With infection control measures, we should always reduce the manipulation of every component of the entire infusion system, and this will help reduce the risk of contamination. Making sure that we're performing hand hygiene before and after all infusion procedures. This includes not wearing artificial nails when performing infusion therapy procedures. Tourniquets and all insertion equipment are to be single client use. We use gloves for catheter insertion. We scrub the insertion site with a skin antiseptic agent and allow it to dry completely. Touch the cleansed skin with sterile gloves only. In other words, once you clean it, it's sterile. Do not touch it. Ensure sterile dressing is intact. Infection occurs more frequently in nutrient-rich solutions such as TPN and blood. Always make sure that you examine the equipment and the solutions for integrity and expiration dates. An ongoing assessment should always be completed to find signs of infection early. All IV injection caps need to be cleansed with 70% alcohol and allowed to dry completely before accessing, unless we have the antiseptic cap placed on an insertion port. Then it is not necessary to cleanse the site prior to use. As far as safety measures, be very careful when you use scissors. It should only be used for suture removal and during the procedure of catheter repair, if that should be necessary. In other words, LPNs are probably not going to be using scissors. They should never be used to remove vascular and non-vascular access device dressings, tapes, or stabilization devices because of the potential of patient injury. It can result in digital amputation in infants. Those scissors are sharp. We could have accidental skin lacerations or severing of the catheter. And always handle and dispose of these items appropriately. Anything that is blood contaminated, the sharps, including but not limited to the needles or stylets, surgical blades, and syringes, have to be discarded in those non-permeable, puncture-resistant, tamper-proof biohazard containers. And never put a discontinued saline lock with the extension tubing in the sharps container. That should always be placed in an appropriate biohazard bag. There is a risk of injury by the sharps in the sharps container to yourself. All biohazard materials and wastes and drugs should be discarded in the appropriate containers. Complications of IV therapy. First of all, in your resources, you have a paper that is entitled Complications of IV Therapy. I highly recommend that you pull this out and look at it. It's going to be a lot more explicit than the information provided here. Complications can be local or systemic, even life-threatening or life-altering. It's important to use appropriate techniques and frequent assessment to identify potential complications and implement appropriate interventions when not in use. Prevention of those complications is going to be very important. Local complications can include infiltration, extravasation, phlebitis, thrombophlebitis, cellulitis, infection, occlusion, and nerve injury. Systemic complications can include air embolism, bloodstream infections, speed shock, circulatory overload, allergic reactions, and adverse reactions to medications. Infiltration is the infusion of non-vesicant fluids and or medications in the tissue that surrounds the catheter. In other words, it's leaked out of the vein at the insertion site. The client may complain of pain or a burning sensation. The site may appear pale, edematous, hard, and cool to touch. Remember, it's fluid that's going into the vein or into the tissue. So now it's nice and cool. We need to stop the infusion and elevate the extremity. It requires discontinuation of the site and obtaining a new site. Extravasation is going to be the infusion of a vesicant fluid or medication into the tissue around the cannula. In other words, infiltration is infusion of non-vesicant solutions into the tissue. Extravasation is infusion of vesicant solutions into the tissue. Inflammation of the vein wall is called phlebitis. Thrombophlebitis is the inflammation of the vein with clot formation. It may be caused by irritation from the cannula or some medications. We may see or feel redness, edema, warmth, and the client may feel pain. It could indicate infection. It does require discontinuation of the site and obtaining a new site. So review the phlebitis scale located in the Complications of IV Therapy document in your resources. Infection. We may see redness along the vein or in the site area, swelling or purulent exudate, warmth to the site, and the client may have an elevated temperature. It does require removal of the catheter, and again, consider culturing the catheter tip. Monitor the client and the IV system for excessive fluid volume. Use flow control devices if possible. A flow control device should always be used in pediatric infusions, preferably in the older adult. If symptoms of fluid volume excess do occur, slow down the infusion rate, elevate their head, and then notify the provider. Do they want you to continue the infusion at a slower rate? Do they want you to discontinue the infusion, etc.? That's the provider's decision. So slow it down and contact the provider. You can always, or these clients sometimes will feel a lot of coolness. They may feel discomfort, burning, or stinging at the site, but there are no symptoms of issues other than their subjective verbalization. An embolus is a foreign object in the bloodstream, and this can be blood clots, air, or a piece of the IV catheter when we're talking IV therapy. The client will experience shortness of air, hypotension, chest pain, and potentially shock or cardiac arrest. If an IV cannula flushes with difficulty, never force it. You just stop because a clot may be dislodged. It's recommended to try and aspirate. If that doesn't work, then you need to, again, just stop, remove the catheter, and we'll start it somewhere else. 10 mLs of air can cause an air embolus. So monitor your IV lines very closely. If an air embolism does occur, we turn the client to their left side. We want to we want to lower their head. This is going to help encourage absorption of the air into the right atrium. Then notify the provider and administer 100% oxygen. Keep that emergency cart close by. These clients are at a high risk of potential life-ending events. Another complication not listed here is speed shock. Speed shock occurs if we push a medication too quickly. So we always have to push a medication at the manufacturer's recommended rate. These are the nursing priorities that can have the most impact on the client receiving IV therapy. The potential for injury includes trauma, infiltration, and extravasation. Potential for infection can be from cannula irritation, medication irritation, non-adherence to aseptic technique, etc. Fluid volume excess can occur in clients that have impaired renal or cardiac functions. Any infusion in which the client does not receive appropriate monitoring is also at risk. And impaired peripheral circulation can occur from emboli or thrombi. And how do we terminate IV therapy? Nursing assessments that may indicate the need to discontinue the site include Now let me clarify before I go any further. Nurses do not have to have an order to discontinue a site. Nurses do have to have an order to discontinue therapy. So issues that may require a nurse to discontinue a site would be infiltration. The site is red, tender, indurated, or really warm to touch, in other words, signs of infection or phlebitis. Evidence of thrombophlebitis, where the vein is hard and very tortuous. The client complains about aching of the extremity. Site infection that's evidenced by drainage. Cannula occlusion, and occlusion can be by a potential clot, and sometimes, somehow, some way, I don't know how this happens, the catheter can actually become kinked within the vein and become occluded. Evidence of cellulitis, suspected IV-related sepsis, a defect of the product, or maybe the client just complains that this site hurts. Please move it. That can be reason enough for us to discontinue a site and place it somewhere else. And then we always put a description of the site and the reason for changing the site in the client's medical record. So during removal, we are going to always inspect the cannula once it's removed. So how do we do this? First of all, we review our order, make sure that we have the order to remove the site if we're discontinuing it, or if for any of these reasons I just mentioned, we're going to loosen the securement device. Then we are going to place a sterile cotton ball or 2x2 over the insertion site, place light pressure, slowly remove the catheter parallel to the skin, then hold pressure on the site. While we're holding pressure, then we inspect that cannula. We need to visually determine if the length of the cannula that we've taken out corresponds with the length that was inserted as noted on the original documentation, and make sure that the catheter tip is not jagged. Sometimes they do break off and become loose, and in that case, we may have an embolus. If there is a suspected embolus, then we need to begin assessing our client for potential emboli. So we're looking at their respirations, looking at their rate, we're auscultating their lungs, etc. We're going to instruct the client to leave the dressing in place for a while. Make sure that that bleeding has stopped. We want to achieve hemostasis. They should avoid rubbing, scratching, or bumping the site because that may start it bleeding again. They should notify the nurse if they note renewed bleeding, pain, or discomfort developing. And the nurse should always document any education that is provided. In addition to documenting the appearance of the site, the condition of the catheter on removal, and how the client tolerated the procedure.